ये हो गया. Hello, dear friends, and welcome to Physiology. I am Dr. Anupama Chaudhary Devgan, your Physiology faculty. So I've lined up 25 most important topics as far as F&G exam is concerned. I know that all of you have been studying very hard, preparing for the exam in January. I know that there is a lot of effort which has gone into reaching this place. Trust the effort that you have put in, trust your capability, and I'm sure you will come out winners. As far as physiology is concerned, now these 25 topics that we're going to discuss today are extremely important. They have been asked very frequently in your exam. I will also be discussing some one-liners so that, you know, our preparation for, as far as physiology is concerned, is complete. So without wasting any time, let's start. And let's start with our first question. And good evening, everyone. There are quite a few of you which have logged in. Yes, nice to see you too, Sandeep. Yes. Okay. Okay, fantastic. Good evening to all of you who have logged in. So let's start with our physiology questions. But before I do that, I have to give you some gyan, isn't it? That is what your mentors are meant for, just to help you and help you with making sure that you face this exam with all confidence. Now, a very important line that here, which says you don't have to be perfect every day, just consistent. You have to show up every day, have to make sure that you are reading every day, revising every day. So it's not that you have to be extremely, you have to have very high IQs to max this exam. No, what is more important is consistency. वो कहते हैं ना कि अगर आप रोज एक लड्डू खाओगे तो वो तो पच जाएगा. अगर ये सोचो कि नहीं मैं एक दिन 30 लड्डू खाऊंगा तो वो नहीं होगा, isn't it? So consistency is the key. All right. Yes, of course. We will world gaming. Yes, you will get help with all the questions. I'm going to spend a lot of time on every question so that there is no doubt. Okay, so let's have a look at a topic which is asked again and again, and that is on positive feedback. Excellent, are you ready? Yes, everybody will pass the exam with flying colors, definitely. This is the attitude with which we are going to study, with a lot of positivity. Yes, and we will do very well in the exam. So let's look at the first question that says positive feedback. Positive feedback of which of the following hormones on LH causes the LH surge just before ovulation? Now, this LH surge is done by, yes, absolutely right. This is going to be estrogen. Estrogen causes what is known as the LH surge, which is responsible for ovulation. Now, as far as the LH level is concerned, the LH level throughout the menstrual cycle is very low. There is a low LH, and this low LH is mainly because of negative feedback of estrogen on the secretion of LH. LH comes from the anterior pituitary. So estrogen now, because of a negative feedback, reduces LH. So throughout the menstrual cycle, there is a very low LH. This is because of a negative feedback of estrogen on LH. But just before ovulation, this negative feedback effect of estrogen on LH switches. And this negative feedback becomes positive feedback. So what is positive feedback? Estrogen now increases LH, which in turn increases estrogen, which increases LH. So we get a sharp increase in LH secretion. This is what is known as the LH surge. This LH surge is because of a positive feedback of estrogen on LH. Then now The positive feedback again switches back and becomes negative feedback. From positive, when it becomes negative feedback, what will happen to the LH levels? The LH levels will fall and become very low again. The LH surge, which occurs just before ovulation, is because of a positive feedback of estrogen on LH. Now, this is what is positive feedback. Now, this is an extremely important point here. Which are the hormones which are regulated by positive feedback? Most hormones are regulated by a negative feedback. But the hormones which are regulated by positive feedback is LH, oxytocin and prolactin. Oxytocin and prolactin, when the mother is feeding the baby, suckling by the baby causes an increase in oxytocin, which causes the milk let down reflex, and that causes even more suckling by the baby, more release of oxytocin, more milk let down reflex. And similarly, suckling by the baby causes increase in prolactin, and which causes increase in the milk secretion, and again more suckling, more release of prolactin. So these are three hormones which are regulated by positive feedback. All other hormones are regulated by negative feedback. Absolutely right. I have CLAPS, which has come up. What is CLAPS? That is my next slide here. What are the examples of positive feedback? So C is clotting. Blood clotting is an example of positive feedback. C is also calcium release from the sarcoplasmic reticulum during a muscle contraction. That is also known as a calcium-induced calcium release. Please remember, calcium-induced calcium release is seen in skeletal muscles, in cardiac muscles, and also in smooth muscles. But please remember, in skeletal muscle, the source of calcium is only the sarcoplasmic reticulum. In cardiac muscle contraction, the source of calcium is ECF mainly, but also the sarcoplasmic reticulum. But in smooth muscle, the major source is the ECF, with only a small amount of calcium coming from the sarcoplasmic reticulum. Okay, sorry for that. LH surge, and the milk letdown reflex, which I just told you about. The secretion of oxytocin is by a positive feedback mechanism. The A stands for action potential, A for activation of inactive pancreatic enzymes to their active form. This is also by a positive feedback mechanism. P stands for parturition. The process of delivery is a positive feedback mechanism, and uncompensated or decompensated shock is an example of positive feedback. Absolutely right. The mnemonic is CLAPS, CLAPS. Great. So everybody is okay with this question, it appears, right? Okay, let's go on to our next question. Okay. Now, this is again a very important topic about glucose transporters. Has been asked again and again. Different questions from glucose transporters. I will try to cover up all the questions which have been asked from glucose transporters. Firstly, glucose transporter is an example of facilitated diffusion. Facilitated diffusion. And what is facilitated diffusion? Facilitated diffusion, is it an example of active transport or passive transport? This is a passive transport. This is a passive transport, right? And this is passive, means a longer concentration gradient, does not need energy. But this is a carrier-mediated transport. And whenever carrier proteins are involved, there is going to be saturation, a maximum rate of transport. Maximum rate of transport. So that means it is saturable. There is a saturation which happens, and because of the saturation, there is a transport maxima. The maximum rate of transport will be seen in facilitated diffusion. So these are 3 very important points as far as GLUT is concerned, glucose transporter is concerned. Now the question says, which is the insulin-dependent GLUT? The only insulin-dependent GLUT is a GLUT4. And this is present on adipocytes, on the muscle cells, and to some extent also on the liver. Yes, absolutely right. Achal Dubey, you will get the PDF. This time I will make sure that I will save the PDF and it will be put up, I think, in your group, in the MIST group, right? So you will get the PDF. All right. So insulin-dependent GLUT is present on adipocytes. GLUT4, this is GLUT4, which is present on adipocytes and on muscle cells. Okay. Okay, Naveen Chaudhary, I'll try to moderate my accent a little bit, if that is troubling you. Okay. So let us see this. What are the major sites? What are the different GLUTs and what are the sites? Now, this is a question which is asked again and again, right? What are the different sites? And there is a little mnemonic to remember this. Remember brain, beta, brain, fat fruit. Now, what does that mean, right? What is this? Brain, beta, brain. Fat fruit. Brain, beta, brain, fat fruit. So GLUT1 is present on the RBCs. The blood-brain barrier, very important. You must understand that when the glucose in the blood cannot just cross and enter the brain cells, because there is a blood-brain barrier. Blood-brain barrier does not allow a free movement of substances from the blood to the brain cells. So the GLUT which is present on this blood-brain barrier is GLUT1. So brain, beta, brain, fat fruit. So first is GLUT1 is blood-brain barrier. It is also present on RBCs. It is present on the placenta and the cornea. GLUT2, beta cells of pancreas, very importantly, present in the liver, in the kidney, BCT, intestinal mucosa on the basolateral membrane. GLUT3, brain, on the neurons, GLUT3 and placenta. GLUT4 is the insulin-dependent GLUT which we have just discussed. It is present on adipocytes, skeletal muscles, cardiac muscles. GLUT5, so brain, beta, brain, fat fruit. This is fructose. It is a specific fructose transporter. This is present in the jejunum and on the sperms. GLUT6, brain, spleen, WBCs. GLUT7 is liver. So this is an extremely important table that you have to try and remember because questions are asked from here. Now, which is a glucose sensor? Glucose sensor is GLUT2. Which GLUT has the highest affinity for glucose? This is GLUT3. Which is the insulin-dependent GLUT? GLUT4. Which is a specific fructose transporter? GLUT5. Such important, all these questions have been asked in your exam. So an extremely important table that we have to know. Abhi Reddy, it is GLUT4 which is insulin dependent. Oh, you're saying all the others are insulin independent. Abhi Reddy, GLUT1, GLUT2, GLUT3, GLUT5, GLUT6, 7 are all insulin independent. GLUT5 is a specific fructose transporter. Which GLUT is present on the beta cells of pancreas? GLUT2. which is the GLUT which is present in the kidney, in the intestine, GLUT2. These are all insulin independent. The only one which is insulin dependent is GLUT4. Is that all right? Are we ready? Okay. Let's go on to our question number 3. Which of the following electrolyte imbalances results in increased nerve excitability? Which of the following electrolyte imbalances results in increased nerve excitability? So the first one is hyponatremia. Now please remember, a hyper or a hyponatremia does not affect nerve excitability. Hyponatremia will cause a decrease in the plasma osmolality. Does not affect the nerve excitability. It only affects the plasma osmolality. Hypernatremia increases plasma osmolality. Hyponatremia decreases plasma osmolality. Hypokalemia. Hypokalemia causes whenever there is a decrease in the plasma potassium level, it causes a hyperpolarization. What is hyperpolarization? The resting membrane potential becomes more negative. Hyperpolarization, which decreases the neuronal and muscle excitability. Decreases neuronal and muscle excitability. Hypocalcemia, whenever there is a decrease in the plasma calcium level, this increases the neuronal and muscle excitability. So answer becomes hypocalcemia. Absolutely right, Yasir Khan. Schwastek sign positive, carpopedal spasms. These are typically seen in hypocalcemia. Hypocalcemia. Hypochloremia also does not affect the neuronal excitability. So the answer to this is going to be hypocalcemia, a decrease in the plasma calcium level. This is also known as the Trousseau sign, carpopedal spasm. This is typically seen in hypocalcemia. This is called hypocalcemic tetany. These carpopedal spasms, absolutely right. Abhi Reddy and Sahil Kushwaha, this is carpopedal spasms. These are known as Trousseau's sign, hypocalcemic tetany. Clear. Now, again, an important table which will help you answer quite a few of your questions, and that is what happens in hypokalemia. In hypokalemia, there is a hyperpolarization. Resting membrane potential becomes more negative, which decreases the nerve and muscle excitability. Mild to moderate hyperkalemia causes a depolarization. Resting membrane potential becomes less negative, and that causes an increased excitability. These arrhythmias are a common complication of a mild to moderate hyperkalemia. But in a severe hyperkalemia, there is in fact a decreased excitability. There is a decreased contractility. The systoles of the heart will become weaker and weaker. Heart becomes flaccid and heart will stop in diastole. So that is seen in severe hyperkalemia. Hypocalcemia, increased neuronal and muscle excitability. We've just discussed the Trousseau sign, carpopedal spasm, Schwastek sign positive, obstetric hand, absolutely right. So this is an extremely important table. What are the problems when there are electrolyte imbalances? Abhi Reddy is right. So hypokalemia will cause a decrease neuronal and membrane excitability, muscle excitability. Mild to moderate hyperkalemia increases excitability. Arrhythmias are commonly seen, but severe hyperkalemia decreases excitability. And that is why there is a decreased contractility, weak systoles, heart becomes weaker and weaker, becomes flaccid, and stops in diastole. In hypocalcemia, increased neuronal and muscle excitability. So this is as far as your electrolyte imbalances are concerned. Let's have a look at one-liners from general physiology. Let me see how many of you are going to answer this. This normal plasma osmolality. Let's see the answers. Normal plasma osmolality. Okay, this is going to be normal plasma osmolality. I'm waiting. 280 to 290 milliosmoles per liter. If you have to choose one value, then your answer will be 290 milliosmoles per liter. 280 to 290, absolutely right. Maximum contributions, let's see the next one. Maximum contribution to plasma osmolality is by. Most of you have got the first one right, 290. Excellent. Maximum contribution to plasma osmolality. My second question, second one-liner. Maximum contribution to plasma osmolality is by sodium. Sodium. Changes in the plasma sodium level will affect the plasma osmolality. If there is a hypernatremia, plasma osmolality increases. If there is a hyponatremia, plasma osmolality decreases. Excellent. Nitesh, Uday, Danav, Ananya, Vishal, all of you have got it right. Yes, absolutely. Diamond, Shailendra Kaushik, excellent. Normal colloid osmotic pressure, which is also known as oncotic pressure. Let me see. Normal plasma colloid osmotic pressure or oncotic pressure. This is 25 to 28 millimeters of mercury. 25 to 28 millimeters of mercury. What is colloid osmotic pressure or oncotic pressure? This is the pressure exerted by the proteins in plasma. And which is, excellent, Abhi Reddy, all of you, 25 to 28, excellent. Which protein contributes maximum to plasma colloid osmotic pressure or the oncotic pressure? This is albumin. Albumin. So if there is a hypoalbuminemia, it will decrease the plasma colloid osmotic pressure. It will decrease the oncotic pressure. Hypoalbuminemia, which clinical condition will cause a hypoalbuminemia? Nephrotic syndrome, liver cirrhosis. Albumin is produced by the liver. So anything which decreases liver function will decrease the plasma albumin levels, cause a hypoalbuminemia and a decrease in the plasma colloid osmotic pressure. Next question, blood-brain barrier. It is formed by what? It is formed by the tight junctions between the endothelial cells of cerebral capillaries. Blood-testes barrier, on the other hand, is formed by tight junctions between the Sertoli cells. Blood-brain barrier prevents free movement of substances between the blood and the brain cells. Blood-testes barrier protects the developing sperm from harmful agents in the blood. And this blood-testes barrier is formed by tight junctions between the Sertoli cells. Next important point, sodium-potassium ATPase pump. Whenever the ATPase enzyme is present, that means it uses ATP. That means it needs energy. And whenever a transport protein needs energy, we call that active transport. So sodium-potassium ATPase pump is an example of primary active transport. Absolutely right. Explore, Nitesh, Rohit, Seem 789, Sheila. Absolutely correct. Primary active transport. Very good. carrier-mediated transport, which does not require energy. A carrier protein is involved, but there is no energy is required. What is this going to be? This will be, I've just spoken about GLUT. What is that? That is a carrier-mediated transport, does not require energy. What is that an example of? That is an example of facilitated. Absolutely right, Nitesh. Sunny, Paneri, fantastic. I'm so happy. Facilitated transport. Excellent, excellent. Yes, Vishal, absolutely right. So this is an example of facilitated diffusion or facilitated transport. It is carrier-mediated but does not require energy. A carrier-mediated transport which requires energy is active transport. If ATPase enzyme is present, that is a primary active transport. Excellent. Let's see question number 4. Now, this is from Nerve Physiology. Let's see, this says now, CNS examination is being performed on a patient with a stroke. With the patient's eyes closed, his big toe is moved up and down while holding his proximal metatarsophalangeal joint. By holding the proximal, you have to keep the hold the metatarsophalangeal joint to keep it stable. And then you move the toe either upwards or downwards and ask the patient what is the position of his toe. This is what is known as testing for what sensation? This is testing for proprioception. 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 Which of the following fibers is responsible for the transmission of the sensation tested here? Is it going to be A alpha, A beta, A gamma, or A delta? You know there are 3 types of nerve fibers, type A, type B, and type C. Type A is further subdivided into A alpha, A beta, A gamma, A delta. Now, what are these meant for? So first, let me discuss with you what are these different nerve fibers meant for, and then we'll discuss what is the best answer. Now, A alpha is your motor fiber. This is somatic motor. A alpha is also meant for proprioception. Proprioception. A alpha is also meant for proprioception. A alpha will carry proprioception from two very important proprioceptors. And which are these? What is a proprioceptor? These are receptors for proprioception. And which are the 2 most important receptors for proprioception? Muscle spindles and Golgi tendon organs. So A alpha fibers carry proprioception from muscle spindle and the Golgi tendon organ, carry the sensation from both muscle spindles as well as the Golgi tendon organ. A beta is meant for fine touch. It is meant for vibration. It is meant for deep pressure. And it is also meant for proprioception. But A beta nerve fibers will carry impulses only from muscle spindles. A alpha are carrying impulses from both the muscle spindles as well as the Golgi tendon organs. A beta will carry proprioceptive input only from muscle spindles. A gamma is motor to the muscle spindle. It's a motor fiber. A alpha and A gamma are both motor fibers. A alpha are larger ones and A gamma are smaller. And like I said, they are motor to muscle spindle. A delta is also a sensory fiber. This is meant for what is known as fast pain. It is meant for temperature. In temperature, it is meant for cold sensation. And it is also meant for some mechanoreception. What is mechanoreception? Mechanoreception are different forms of touch, right? So this is what the type A fibers are meant for, right? So A alpha, somatic motor, this is the motor neuron, which is responsible for movement. A alpha can also be sensory. They carry impulses from proprioceptors. Which are the proprioceptors? Muscles, spindles, and Golgi tendon organs. A beta are meant for fine touch, vibration, deep pressure, and also for proprioception, but the proprioceptor here is going to be only the muscle spindle. A gamma is another motor neuron, motor to the muscle spindle. A delta is meant for fast pain, temperature, which is cold sensation, and some mechanoreception. Then you also have, let's just complete this topic. Type B fiber. So A we have discussed, then let's see what is type B. Type B is meant for preganglionic autonomic. The preganglionic autonomic nerve fibers are type B. Let's see what is type C. Type C is postganglionic autonomic. And type C is also meant for crude touch, pressure, slow pain, temperature. In temperature, it is meant for both cold and warm sensation. Both cold and warm. So this is as far as your, what are the function of different types of nerve fibers. So let's go back to the question which I've asked you. What is a better answer as far as proprioception is concerned? Of course, as you can make out, proprioception is carried by A alpha as also by A beta. A alpha muscle spindle and Golgi tendon organ, A beta only muscle spindle. So what is both? If both are given in the options, then my better answer will be A alpha. A alpha is your the answer. If both are given, A alpha and A beta, then my better answer is A alpha is meant for proprioception. Another question which has been asked, which is the fastest conducted sensation? Fastest conducted sensation will be proprioception, because proprioception is carried by A alpha neurons mainly, and so it is going to be the fastest conducted sensation. So please understand, A alpha, A beta, both are involved in proprioception. Some of you have answered A alpha, some have said A beta, but please remember, if I have to choose which is a better answer, I will go for A alpha. Is that clear? Right? Okay. No, it's not a silly mistake. Do not, Diamond, I won't call it a silly mistake. Yes, the reason why I have put these options is because I know there will be a little amount of confusion, but at this point of time, our main goal is to clear that confusion. Let's have clarity at this point. It's going to help us in the exam, right? So so do not guess. A is a better answer as compared to B. Okay, all right. Let's go on to our next question. Now this says, a child was defecating in the open in a village when he was attacked by a pack of dogs. One of the attacking dogs was found dead the next day, so obviously this is probably a case of rabies. Considering the high risk of rabies in the child, he was admitted to the district hospital, was given an anti-rabies serum and Rabipur vaccine. Which of the following is responsible for transport of the rabies virus to the brain? Now here he has been bitten somewhere in a peripheral part. Lower limb, upper limb, somewhere he has been bitten. The rabies virus is going to travel in a retrograde fashion towards the spinal cord and the brain. So basically, this is asking you which is the protein which is involved in a retrograde axoplasmic transport. And everybody seems to have got it right. And that is Sunny, Rohit, Sahil, Nitesh. Absolutely right. And this is going to be dynein. Dynein is the molecular motor which is involved in retrograde transport. Absolutely correct. Absolutely correct. Ananya says, better to make a mistake here than in the exam. Absolutely right. This is the point where you are allowed to make mistakes, and let those mistakes happen, because so that if there is any confusion, we want to end up clearing that particular confusion. Okay. So when I look at axoplasmic transport, what is axoplasmic transport? Now, for instance, if this is the cell body, this is a neuron, this is the terminal part of the neuron, movement through the axon, a physical transport of substances through the axon is known as axoplasmic transport. It can be from the cell body till the end of the neuron, which is called anterograde transport. Anterograde means aage, right? Or if the transport is in the reverse direction from the terminal towards the cell body, that is called retrograde, piche ki taraf, right? From the cell body towards the nerve ending, it's called anterograde, and retrograde will be towards the cell body. Now, axoplasmic transport has been classified into fast and slow axoplasmic transport. Fast and slow axoplasmic transport is the only difference is speed. Fast axoplasmic transport is further subdivided into anterograde and retrograde. Anterograde, away from the cell body, retrograde, towards the cell body. Anterograde fast axoplasmic transport, anterograde, this is 400 millimeters per day. Slow is always anterograde. There is no retrograde, slow retrograde. Slow anterograde is 0.5 to 10 millimeters per day. So you can make out the difference between fast anterograde and slow anterograde is only in terms of speed. Now, which are the molecular motors which are involved in anterograde transport are kinesin and myosin 5. What are the substances which will be transported in an anterograde direction? Anything produced by the cell body, right? What does the cell body produce? It produces what are known as neuropeptides. Synthesis of peptides is done by the nucleus in the cell body. So neuropeptides, vesicles, mitochondria, lysosomes, reticulum, they will move away from the cell body, anterograde. What is retrograde? Retrograde speed is 200 millimeters per day. The molecular motor, as you've just answered, is going to be dynein. And what travels in a retrograde direction? Neurotropic viruses, like we just discussed the rabies virus. Neurotropic viruses. Nerve growth factors. These move in a retrograde direction towards the cell body. So the answer here, as most of you, as all of you in fact, said is dynein, right? Absolutely right. World Gaming, thank you very much, and hope that you get all the questions from what we are discussing today. That will be the ultimate. So this is axoplasmic transport, and your answer to that question is dynein. Now, one-liners from nerve physiology. Let's look at these. Yes, absolutely right. Rabies, CMV, Epstein-Barr, measles, mumps, all of them are going to go in a retrograde direction. So neurotropic viruses, absolutely right. Now let's see the one-liners from here. RMP of most neurons. RMP of most neurons is minus 70 millivolts. RMP of most neurons minus 70 millivolts. Next important question. RMP is mainly due to which ion? Is it due to sodium, potassium, calcium, magnesium? This is going to be mainly due to potassium. Potassium ion is responsible for the resting membrane potential. Why is potassium responsible for the resting membrane potential? Because the cell membrane at rest is maximally permeable to potassium. The most diffusible ion at rest is potassium. Excellent. Nidesh, Abhireddy, Sheila. Wonderful. Rohit, Nilesh, excellent, excellent. I'm so happy that all of you are answering absolutely correctly. Let's look at the next one-liner. Depolarization phase of the action potential. This is depolarization, the upstroke. What is it due to? The upstroke is due to an influx of sodium. Then you have a downstroke of the action potential. The downstroke or the repolarization is due to efflux of potassium. Efflux of potassium. Excellent. I can see all correct answers. Absolutely right. Yes. The upstroke or the depolarization is due to sodium influx, and the repolarization is going to be due to a potassium efflux. Absolutely correct. Okay, fantastic. Let's look at the next one. Large diameter myelinated nerve fibers are the fastest conducting, just like we have just discussed. Which is the largest diameter and the fastest conducting fiber? That is going to be A alpha. Which are myelinated? Type A and B are myelinated. But what is not myelinated is type C. Type C is small diameter and unmyelinated. So fastest conducting nerve fiber will be type A, or out of that is A alpha. Slowest conducting nerve fiber will be type C. Type C is the slowest conducting. Small diameter and slowest conducting. So Prem Kishore, the nerve fiber from Pacinian corpuscle is A beta. Beta, please be careful. Prem Kishore, nerve fiber from Pacinian corpuscle is A beta. Okay? All right. So the rest of you have got it absolutely correct. Fantastic. Yes, ready to move on to the next one? Ready to move on to muscle physiology? Okay, yes. For vibration is Pacinian corpuscle, that is A beta. A beta. Vibration is Pacinian corpuscle, which is A beta. Prem Kishore? बिल्कुल सही है. Pacinian corpuscle के लिए, Pacinian corpuscle vibration के लिए है, लेकिन जो nerve fiber है Pacinian corpuscle से, that is A beta. ठीक है? प्रेम किशोर? A alpha किसका sensory fiber है? मैं बता चुकी हूँ आपको. Muscle spindles and Golgi tendon organs. Muscle spindle और Golgi tendon organ किसके लिए है? Proprioception के लिए. Fastest conducted sensation कौन सी है? Proprioception. सही है? Everybody is okay with that? प्रेम किशोर? ठीक है? Right? Fastest conducted sensation, proprioception. Not vibration, proprioception. Absolutely fine. Let's go on to the next one, and this is muscle physiology. A cross-sectional view of the skeletal muscle fiber through the H zone. You know there are different bands. There is an A band, there is an I band, and there is an H zone. This would reveal the presence of which of the following? और ये सार्कोमियर का डायग्राम मैं आपके साथ क्लास में कितनी बार कर चुकी हूँ, और ये बहुत ही ज़रूरी है ना? बहुत ही ज़रूरी है. And this is, what is the sarcomere? This is the structural and the functional unit of the skeletal muscle. Structural and functional unit of the skeletal muscle is called the sarcomere. ठीक है? Sarcomere is between the two Z lines. ये एक Z line है, and this is your Z line. So what is extending between the two Z lines is going to be the sarcomere, right? So C is sarcomere. Sarcomere kahan se kahan tak hai? From one Z line to the other Z line. So you've got a sarcomere. Within the sarcomere, you have a dark band or an A band. And what is this dark band or A band? This consists of myosin plus overlapped actin. Myosin plus overlapped actin. Within the dark band or the A band, you have a slightly lighter area which is called the H zone. And H zone is only myosin. ठीक है? Sarcomere दो Z lines के बीच में है. There is a dark band which is myosin plus overlapped actin. Within the dark band, you have a slightly lighter area which is called the H zone. H zone is only myosin. On either side of the A band is the I band. I band. And what is this I band? I band is only actin. और याद रखें, half of I band एक sarcomere में है and half of I band is in the neighboring sarcomere, right? And I band is only actin. So once again, A band, myosin plus overlapped actin, H zone only myosin, I band only actin, right? And ये है half of I band. Yes, so going back to my question here, so if you look at the H zone will be myosin only. Myosin only, right? Yes, absolutely right. Myosin only. Everybody seems to have got it right. That is Avani, Diamond, Sahil, Jubar, Ali, Rohitanand, Digvijay, all of you. Uday, Nitesh, everybody's got it correct. So this is going to be myosin only. This is a slightly lighter area within the dark band. This is only myosin. Dark band is myosin plus overlapped actin. Chaliye, agla question. A child is brought by his mother with complaints of weakness, difficulty in walking and climbing stairs from childhood. She also states that he is not able to do day-to-day activities. Upon inspection, his calves are bilaterally hypertrophied. Gover's sign is positive. Gover's sign, what is Gover's sign? When you ask the child to get up from the sitting position, he's sitting on the floor and he tries to get up, he will climb on himself. What does that mean? He takes the support of his own body to get up. He gets up like an old man. Right? That is known as the Gover's sign. And Gover's sign is typically seen in which clinical condition? A clinical condition where there is no functional dystrophin. No functional dystrophin. What is dystrophin? Dystrophin is a sarcolemmal protein. Which of the following is the most probable diagnosis? Duchenne's or Becker's? Duchenne's is dystrophin. In D for Duchenne's, D for dystrophin. Dystrophin is deficient. A deficiency of dystrophin is Duchenne's. So D for Duchenne's, D for dystrophin, D deficient. Becker's muscular dystrophy, dystrophin is present but is reduced. That is Becker's. Remember, Becker's is better. That means Becker's is better. That basically means that his symptoms are less severe as compared to Duchenne's. So this question, this is going to be, why have I not got your answers? Yes, partial loss in Becker's. Becker's में कम होगा. Yes, A is the answer. Duchenne's muscular dystrophy. Duchenne's muscular dystrophy. Proximal muscle weakness. Severe proximal muscle weakness. It's an X-linked disorder. Absolutely right. And this is Becker's is better. A, absolutely right. Nitesh. Yes. So if you look at this, these are your sarcolemmal proteins. Now, what are sarcolemmal proteins? Now, please remember that the muscle fiber muscle fiber is equal to the muscle cell. So the membrane of the muscle fiber is known as the sarcolemma. So these are proteins which are found in the sarcolemma. So they're called sarcolemmal proteins. This is also known as the dystroglycan. Dystroglycan, sarcoglycan complex. Dystroglycan, sarcoglycan complex. So which are these sarcolemmal proteins? Let's see that. The sarcolemmal proteins are, number one, dystrophin. Number two, syntropin, sarcospan, dystroglycan alpha and beta. And number five, you have sarcoglycan. So these are five important proteins which are present in the sarcolemma. They form the dystroglycan-sarcoglycan complex. Which are these five proteins? Number one, dystrophin, syntropin, sarcospan, dystroglycan, sarcoglycan. Now, if there is a mutation of any of these proteins, patient presents with proximal muscle weakness. The most severe one is when dystrophin is absent. Dystrophin is deficient in leucines. D-dystrophin, D-deficient, D-leucines. If dystrophin is present but reduced, Becker's. Becker's is better. If there is a mutation of sarcoglycan, the condition is known as limb-girdle dystrophies. Limb-girdle dystrophy. Right? So this is as far as your these dystroglycan, sarcoglycan complex is concerned. Okay, so I think there is a little bit of confusion, or the best way to remember: dystrophin deficient leucines, dystrophin deficient, DDD. Becker's में dystrophin, functional dystrophin present है लेकिन कम है. Somebody said Becker's is beggar. If that helps you to remember, that's also fine. Okay. Yes, Gover's दोनों में मिलेगा. Gover's sign will be seen in both. But functional dystrophin is absent in leucines, present but reduced in Becker's. All right. So this is as far as your the dystroglycan-sarcoglycan complex is concerned. Okay. So answer is leucines. Next. A patient, now this is again a very, these sarcolemmal proteins, transmission across neuromuscular junction, and the diseases, myasthenia gravis, Lambert-Eaton syndrome, very, very frequently asked. Yes, world gaming, absolutely right. So a patient presents with unilateral drooping of eyelid, there is muscle weakness, there is headache, symptoms worsen during the evening. So here is a big hint. Patient feels better after taking neostigmine. What does neostigmine mean? It is an anticholinesterase. What is the most probable diagnosis of the patient's condition? This is a myasthenia gravis. Myasthenia gravis. Myasthenia gravis is a disease of the postsynaptic membrane. Here, the antibodies are against the acetylcholine receptors. Why does he feel? What happens in myasthenia gravis is like exactly what you said, morning must hai. That means he feels okay when he gets up, but during the day, his weakness worsens. Towards the end of the day, he feels extremely weak. The muscle weakness becomes prominent towards the end of the day. He feels better after a period of rest. And by taking neostigmine, what is neostigmine? It's an anticholinesterase. By taking neostigmine or physostigmine, this causes a local increase in acetylcholine at the neuromuscular junction and improves his symptoms. This is, so let's have a look at the neuromuscular junction. How does transmission across the neuromuscular junction take place? When the action potential reaches here, there are these voltage-gated calcium channels. These voltage-gated calcium channels will open. There is an influx of calcium. This causes exocytosis of acetylcholine. Acetylcholine will diffuse across the synaptic cleft, bind with acetylcholine receptors. Acetylcholine receptors are on the muscle fiber membrane. A disease of the presynaptic membrane where antibodies are against the voltage-gated calcium channels, that is Lambert-Eaton syndrome. A disease of the postsynaptic membrane where antibodies are against the acetylcholine receptors, this is myasthenia gravis. In a patient of Lambert-Eaton syndrome, of Lambert-Eaton syndrome, his typical complaint will be that his in a patient of Lambert-Eaton syndrome, his typical complaint will be that his maximum weakness will be when he gets up. Early morning maximum weakness. His weakness improves as the day progresses. But in the case of myasthenia gravis, mornings must have. That is, he feels best early mornings, but his weakness worsens as the day progresses. Absolutely right. So this is transmission across neuromuscular junction. Okay, let's go on to our next topic. Absolutely right. I think all of you seem to have got it correct. World gaming, blue color is more in background. What are you trying to tell me? Yellow color is okay? I'm using yellow. Is that all right? Okay. All right. So one little bit of a motivation here. Yes, there is sometimes confusion, but confusion now is clarity later. So we are not going to get bothered by if there is any confusion, because this will give rise to clarity later. It's better to make mistakes now than to make mistakes later. All right, so let's go on to our next question. Okay, all right. Let's have a look at the next one. A 32-year-old man is brought to the emergency department after a stab wound to the right side of his back at the level of T10. Thank you, Ananya. I'm glad our duty as a mentor is not only to help you with the subject, but of course to keep you motivated, to keep your spirits high. And that is so important. I feel that these competitive exams are more a battle of nerves. Somebody who is able to keep his confidence, to keep the faith in himself, is able to do much better during the exams. So never lose that. Trust yourself. Always, always trust yourself. You've done a lot of hard work, and I'm sure it will give you very good results in the exam. Right. So right side of his back at the level of T10. On neurological examination, the following findings were noticed. There was loss of motor power in the right lower limb. There was loss of vibration and proprioception on the right side. Vibration and proprioception are carried by the posterior column. There was loss of pain and temperature on the left side, opposite side. Pain and temperature is carried by the spinothalamic tract, especially lateral spinothalamic tract. Which of the following best explains the pattern of neurological deficit? This is the Brown-Sequard syndrome, and this is a hemisection of the right side of the spinal cord at T10. Absolutely correct. And I see this over here. Nitesh has got it right. Yasha Tiwari, Uday Kiran, Sheila Sahani, Jubair Ali, sab bilkul sahi. Uday, Ananya, World Gaming, Yasir Khan, bilkul sahi. Bilkul correct. Absolutely right. So there is, I can see all of you have pain and temperature opposite is the big hint. Absolutely right. That is what we are going to look at. When you look at a hemisection of the spinal cord, here is the spinal cord. A hemisection means that half of the spinal cord has been cut. If I look at it like this, that means one half of the spinal cord has been cut. In this case, this is a stab wound, which has caused, it's a traumatic hemisection. Hemisection of the spinal cord can be a vascular injury. It could be a tumor. But like in this case, there is a trauma. So the three most important features of Brown-Sequard syndrome, which we are going to keep in mind, the first one is bus stop. What is bus stop? Brown-Sequard, temperature, pain of the opposite side are going to be lost below the level of lesion. Temperature, pain of the opposite side will be lost below level of lesion. Temperature and pain are carried by the lateral spinothalamic tract. Fibers of this tract cross over to the opposite side and ascend upwards. So pain, temperature loss will be opposite side below the level of lesion. Posterior column sensations will be lost on the same side. What is carried by posterior column? Fine touch, proprioception, vibration, two-point discrimination, localization, stereognosis. This is carried by the posterior columns. Motor paralysis. Motor tract, corticospinal tract descends downwards. Corticospinal tract crosses the decussation of the corticospinal tract to the motor tract is in the level of the medulla. So from the cortex, crosses at the level of medulla and descends downwards. So if there is a hemisection of the spinal cord, motor paralysis will be on the same side. So same side motor paralysis. Absolutely right. So this is going to be your three most important features of the Brown-Sequard syndrome. World Gaming, yes. I'm doing these clinical questions with you. These are integrated questions with physiology. The reason why I'm focusing on clinical questions is so that you can use all your knowledge of physiology and answer these questions. But at the same time, I'm also trying to do the one-liners with you so that by the end of this particular session, you have revised a big chunk of your physiology. Absolutely right. So let me see. Yasha Tiwari, आप क्या पूछ रहे हैं कि मेडुला के अपर पार्ट की लोअर पार्ट में लोअर मेडुला is where it cross होता है. Okay. All right. Let's look at the next question. Question number 10. It says a 64-year-old man with a history of hypertension and atrial fibrillation is brought to the emergency department with sudden onset of the right side, sudden onset weakness of the right side of the body and difficulty in speaking. ठीक है? On neurological examination, he has a right-sided spastic paralysis of face, arm and leg. Hyperreflexia and extensor plantar on the right side. Features right side ke hain. So that means it seems to be a right-sided, it is in fact a right-sided hemiplegia. Deviation of the tongue to the right on protrusion. Impaired speech but preserved comprehension. CT scan of the brain shows an ischemic infarct involving the internal capsule. So obviously if it's a right-sided hemiplegia, which internal capsule has been affected? This will be the left internal capsule. Damage to which of the following tracts is primarily responsible for the patient's motor deficit? Now, this question is, yes, these are all UMN symptoms. This is a UMN lesion. Site of lesion is the internal capsule. The commonest site of lesion is the internal. The commonest lesion involving the central nervous system is the internal capsule. But the effect will be on the opposite side of the body. So this is a typical UMN symptoms. The question says damage to the which of the following tracts is primarily responsible for the patient's motor deficit. So basically this question is asking you which is the motor tract which is going to be affected here. Now answer this question very carefully. Jubair Ali, FMG aspirant, Prem Kishore, थोड़ा सा ध्यान से आंसर कीजिए. यासिर खान, बेटा ध्यान दीजिए, इन 4 ऑप्शंस में से आपके मोटर ट्रैक्ट्स कौन से हैं? क्यों यहां कंफ्यूजन हो रहा है? प्लीज थोड़ा ध्यान से देखिए. अभी रेडी? मोटर डेफिसिट. मोटर ट्रैक्ट कौन सा है? मोटर ट्रैक्ट, 2 मोटर ट्रैक्ट्स हैं, कॉर्टिकोस्पाइनल एंड रूब्रोस्पाइनल. प्लीज अंडरस्टैंड फ्रॉम द नेम इटसेल्फ, मोटर ट्रैक्ट्स आर डिसेंडिंग ट्रैक्ट्स. वो कॉर्टेक्स से नीचे डिसेंड करते हैं, है ना? हायर एरिया से स्पाइनल कॉर्ड में डिसेंड करते हैं. 2 मोटर ट्रैक्ट्स हैं, कॉर्टिकोस्पाइनल एंड रूब्रोस्पाइनल. रूब्रो इज रेड न्यूक्लियस. वेयर इज द रेड न्यूक्लियस? इट इज इन द मिड ब्रेन. So cortex is spinal cord and red nucleus of the midbrain is spinal cord. These are 2 motor tracts. Spinothalamic and dorsal columns, these are sensory tracts. These are sensory tracts. They move upwards, isn't it? These are sensory. Question आपसे पूछ रहा है primary motor deficit का कारण क्या है? Your answer is going to be corticospinal tract. Corticospinal tract. Prem Kishore, Vishal. Yes, middle cerebral artery is involved. लेकिन कौन सा motor deficit के लिए कौन सा tract involved है? That is called corticospinal. That is why he has loss of fine skilled movement on the affected side. Corticospinal, absolutely right. उससे पहले आप लोग क्यों C बोल रहे थे? पहले सी क्यों आंसर किया? अब सब ए बोल रहे हैं, राइट? Corticospinal. The 2 motor tracts are corticospinal and rubrospinal. Yes, pyramidal tract, also known as pyramidal tract. Absolutely right. Right? This is corticospinal tract, or the lateral corticospinal tract is the major one which is affected, which is known as the pyramidal tract. That is why he has hemiplegia of the opposite side, isn't it? Rubrospinal, please remember, is a motor tract, but it is not important in humans. In humans, the most important tract as far as motor activity is concerned, fine skilled movement is concerned, is the lateral corticospinal tract, also called the pyramidal tract. Okay, okay. Abhi ready? Okay, शीला साहनी, confusion है. अभी है कि अभी ठीक हो गया? अभी डिस्कशन के बाद, मेरी एक्सप्लेनेशन के बाद अभी कंफ्यूजन है कि खत्म हो गया? ज्यादा दिमाग लगा. All right. Okay, please remember, ध्यान से क्वेश्चन पढ़ना है, right? And whenever you have, right? Whenever you have a question, a long question like this, first have a look at the last line of the question, and then read the complete question. So that also gives you an idea. Now it says motor deficit. Which are the motor tracts? Corticospinal and rubrospinal. Diamond बोल रहे हैं इस टेबल को सेपरेट लिखना होगा तब समझ आएगा. ये हम लोग कर चुके हैं क्लास में. मैंने आपको पूरे टेबल्स सेंसरी ट्रैक्ट्स के और मोटर ट्रैक्ट्स के दिए हैं. सो अगर आप अपनी क्लास नोट्स की तरफ देखेंगे, अगर उनको खोलेंगे तो ये सब वहां पर डिटेल में दिया हुआ है. All the tables, it has been given in a tabular form, right? So remember, it is going to be the descending. Motor tracts are descending tracts. They will come from the cortex and the red nucleus towards the spinal cord. But the most important tract as far as fine skilled movement is concerned is the pyramidal tract. Rubrospinal is not important in human beings. Up to down descending motor. हाँ, so यासिर खान, whenever you get a long question, सबसे पहले last line को सबसे पहले देख लो. because that gives you an idea what is this question trying to ask you, and then go and read the stem of the question. Always do that. जीत जात बोल रहे हैं कि यहां आ जाता है बेटे, एग्जाम में पता नहीं क्या हो जाता है। देखिए बेटा, एक जो आपको चीज याद रखनी है कि एग्जाम में जरूर याद आएगा, क्यों नहीं याद आएगा, बिल्कुल भी। लेकिन एक चीज जो आपको जो आते हुए भी जो आप भूल जाते हो वो है नर्वसनेस। जब बहुत ज्यादा नर्वसनेस होती है, जब आप बहुत डरते हो, तो पढ़ी हुई चीज भी भूल जाते हो। तो वो डर को हमें काबू में रखना है। थोड़ा बहुत तो डर हम सबको लगता है, लेकिन वो जब डर एक्सेसिव हो जाता है, दैट लीड्स टू इनएक्शन। यू अंडरस्टैंड? एक्सेसिव फियर, एक्सेसिव स्ट्रेस, एक्सेसिव एंजाइटी, उसे हमें अपने आप को बचाना है। और वो चीज हम कैसे टैकल कर पाएंगे? आप जब रिपीटेडली सब्जेक्ट्स को रिवाइज करोगे, जो एक ही मंत्र है किसी भी एग्जाम में बहुत अच्छा परफॉर्म करने के लिए, एंड दैट इज रिवाइज रिवाइज रिवाइज। बार बार पढ़ने से फिर याद रहता है, और डेफिनेटली जब एग्जाम में उसके ऊपर क्वेश्चन आएगा, आपको जरूर आप आंसर कर पाओगे। जितनी बार रिवाइज करोगे उतना आपका कॉन्फिडेंस बढ़ता चला जाएगा। कॉन्फिडेंस बढ़ेगा, अपने ऊपर फेथ बढ़ेगा, तो एग्जाम के समय जो डर है वो डेफिनेटली कम हो जाएगा। डर कम होगा तो डेफिनेटली आप आंसर भी बढ़िया तरीके से कर पाएंगे। एब्सोल्युटली राइट। यस, ओके, यस। सो आर्टिक असिस्टेंट आप पूछ रहे हैं कि स्पाइनोथैलेमिक ट्रैक्ट इज मेंट फॉर पेन एंड टेम्परेचर। The lateral spinothalamic tract is pain and temperature. Anterior spinothalamic tract is crude touch, pressure. It is meant for temperature and slow pain. In temperature, both for cold and warmth. Sorry. ये अगर आप देखें, I'll just make this for you. जो spinothalamic tracts हैं, the lateral spinothalamic tract is meant for pain and temperature. Anterior spinothalamic tract is meant for crude touch, itch, tickle, pressure. ठीक है? And sexual sensations. ठीक है? इससे पहले थोड़ा मैंने आपको टाइप सी फाइबर के फंक्शंस बता दिए थे. So this is the correct one. This is your anterior spinothalamic and the lateral spinothalamic tract. Okay, all right. ठीक है? And what are posterior columns कौन से sensations carry करते हैं? That is fine touch, localization, 2-point discrimination, vibration, stereognosis. Right? All this is carried by the absolutely anterior spinothalamic tract for crude touch, pressure, itch, tickle, sexual sensations. Lateral spinothalamic tract is pain and temperature. ठीक है? ठीक है? इन सब के लिए ये जो spinothalamic tract के जो sensations हैं, इन सब के लिए type C fibers हैं. ठीक है? All right. Okay. Proprioception यहाँ रह गया. Proprioception is carried by posterior columns. ठीक है? All right. Great. हाँ विशाल, I had forgotten proprioception. I've added that. Okay, thank you. चलिए, let's go on to. अच्छा, briefly corticospinal tract भी कर लेते हैं. Let's see the corticospinal tract and how it descends downwards. Corticospinal, descending tract, isn't it? So corticospinal tract, let's see, from the cortex, primary motor cortex, premotor, supplementary motor areas, even from the sensory cortex, from the sensory association areas, these fibers descend and they pass through the internal capsule. ठीक है? ये कौन सा tract हम कर रहे हैं discuss? Corticospinal tract. Corticospinal tract. ठीक है? So these fibers, they will arise from different parts of the cortex, from the primary motor cortex, premotor, supplementary motor area, sensory cortex, sensory association areas. All these fibers will pass through the internal capsule. They occupy anterior 2/3 and the posterior limb, anterior 2/3 and the genu of the posterior, anterior 2/3 of the posterior limb and the genu of the internal capsule. These fibers descend downwards. They reach the medulla. Medulla is where the majority of the fibers, 80% of the fibers, will cross over to the opposite side, which is called the motor decussation. Where does the motor decussation happen? At the level of the medulla. This results in a formation of pyramids. Pyramids are seen on the anterior surface of the medulla. It's a bulge on the anterior surface of the medulla, and these fibers form which tract? That is your lateral corticospinal tract, also known as the pyramidal tract. And what is this lateral corticospinal tract meant for? It will control the A-alpha motor neurons which go to the distal muscles. This tract is responsible for fine skilled movement. 20% of the fibers which do not cross, they form the anterior corticospinal tract, and this supplies the A-alpha motor neuron to the axial muscles. Most of the corticospinal tract fibers, 80% in fact, will form the lateral corticospinal tract, which is meant for fine skilled movements. Okay? So this is as far as your corticospinal tract is concerned. So if there is a lesion, remember the internal capsule is supplied by the lenticulostriate branch of the middle cerebral artery. A lesion of the middle cerebral artery, either a hemorrhagic lesion or a thrombus or an embolus, will result in damage to the internal capsule, and patient has hemiplegia of the opposite side. Loss of fine skilled movement of the opposite side. And I've already discussed with you what are the other signs of upper motor neuron lesion in the previous question. ठीक है? तो ये हो गया आपका corticospinal tract. चलिए, absolutely right. Let's go on to question number 11. It says a 25-year-old patient after head trauma presented to the emergency room. On neurological examination, he was found to have a normal handwriting, could copy shapes of objects, but could not speak. Could not speak. Loss of articulation. He's not able to speak. He has an aphasia. What is this aphasia? This is a non-fluent aphasia. This is called a motor aphasia. This will be due to a lesion of the Broca's area. Absolutely right. Sheila Sani, Ayush, Abhi Reddy, you have absolutely got it right. Yes, this is what is known as a non-fluent aphasia or a motor aphasia. So let's have a look at the Broca's and the Wernicke's area. Where is the Broca's area located? Over here. As you can see, this is in front of the inferior end of the motor cortex in the frontal lobe. Broca में बोल नहीं पाएगा, non-fluent aphasia होगा. Absolutely right. Yes, and lesion is called a non-fluent expressive or a motor aphasia. What is Wernicke's aphasia? Wernicke's area is involved in the comprehension not only of the spoken word but also the written word. So there will be difficulty in comprehension, loss of comprehension if there is a lesion of the Wernicke's area. Where is the Wernicke's area? It is the posterior end of the superior temporal gyrus. And the kind of aphasia, he will be able to speak, but that speech will make no sense. That is called a fluent aphasia. Right? So this is as far as, yes, absolutely right. Area 44, 45 is Broca's and area 22 is Wernicke's area. Fluent aphasia. Excellent. Everybody has got it right. So let's go on to the next one. Question number 12. Senseless speaking. Okay, this will be in a lesion of the Wernicke's area. Absolutely right. Nonsensical speech or senseless speaking. Okay. Question number 12. A 58-year-old man presents with progressive unsteadiness while walking and frequent falls over the past 4 months. He reports that, so that means there is an ataxia. There is an ataxia. He reports difficulty in performing fine motor tasks such as buttoning of his shirt. So that means there is loss of coordination, right? Loss of coordination. On examination, his speech is low. It is slurred. He has intention tremor in his right hand. Intention tremor is a typical, it is a hint which says this is a cerebellar disease. Yes? Finger nose testing reveals past pointing. Yes, he's not able to reach his nose, past pointing. So that means loss of coordination again. Muscle strength and sensory examination were normal. So it is a cerebellar disease. But the question I'm asking you is which cerebellar structure is most likely to be affected? Now answer this question very, very carefully. Please remember, cerebral cortical lesions will affect the opposite side. We've done that in the previous question. But in cerebellar lesions, will affect the same side of the body. Now, the symptoms are all on the right side. So this is going to be a right cerebellar hemisphere lesion. Absolutely right. Saddam Hussain. Rohit Anand, Sheila, all of you, Vishal, Sunny, Avni, बिल्कुल सही, लेकिन पूर्वा, आपने A बोला, याद रखिए, a floccular nodular lobe, there is going to be only ataxia and nystagmus. Coordination will be preserved. Coordination will be preserved. But in this question, there is loss of coordination. Past pointing, there is past pointing in the finger nose test. His speech is slurred, right? So this is pointing towards a cerebellar lesion, a lesion of the cerebellar hemisphere. But please remember, cerebellar lesions affect the same side of the body. Is it okay? So Purva, you've got it right now? Okay? Everybody who answered, there were 2 of you who answered A. Is it correct? Okay? So this is going to be, yes, it is an anterior lobe lesion. Prem Kishore, absolutely right. It's a right cerebellar hemisphere, lesion of the right cerebellar hemisphere. Remember, cerebral cortical lesion will affect the opposite side of the body, but cerebellar lesions will affect the same side of the body. Absolutely right. Okay, so you have 3 parts of the cerebellum. There is the vestibular cerebellum, also called the floccular nodular lobe. This is involved in balance and in eye movements. That is why I said a lesion of the floccular nodular lobe will result in ataxia and nystagmus. Spinocerebellum is involved in motor coordination. And cerebrocerebellum is involved in motor planning. Is that clear? Yes. What is option B? Dentate nucleus. Now, dentate nucleus is a nucleus of the cerebellum which is involved in motor planning. So remember, isolated lesions of dentate nucleus are very rare. They do not happen. Generally, it is a cerebellar hemisphere which is affected. Okay? Arctic assistant, have you understood that? Dentate nucleus kya hai? It's a nucleus of the cerebellum. लेकिन isolated lesion of the dentate nucleus is not seen. It's very rare. ठीक है? Generally, it is the hemisphere of the cerebellum which is going to be involved. So the right answer here is right cerebellar hemisphere. Yes, what is dysdiadochokinesia? If there is loss of motor coordination, we call that dysdiadochokinesia. You ask him to perform rapid alternating movements, he cannot do it. Yes, so that is dysdiadochokinesia. Absolutely right. Let's look at the next question. Now it says, a 72-year-old woman with a history of poorly controlled hypertension and type 2 diabetes is brought to the emergency department with sudden onset violent flinging movements of her left arm and leg. Look at this, sudden onset violent flinging movements of the left arm and leg. The movements are irregular, proximal, worsen with voluntary action, but disappear during sleep. Neurological examination is otherwise unremarkable. A non-contrast CT scan of the brain shows a small hemorrhagic lesion. Area has not been specified here. We have to say what is damage to which of the following structures is the most likely cause of the patient's condition. This is a typical case of hemibalismus. In hemibalismus, there are going to be violent, jerky movements involving one half of the body. And hemibalismus is seen when there is a lesion of the subthalamic nucleus. Lesion of the subthalamic nucleus. Absolutely right. Saddam Hussein is sure. He says D is sure. So this is your subthalamic nucleus. Absolutely right. Most of you have got it. In fact, all of you have got it right. So it is in fact a lesion of the subthalamic nucleus, hemibalismus. A lesion of the caudate nucleus causes chorea. What is chorea? Flicking movements, right? Dance-like. A lesion of the globus pallidus gives rise to what is known as athetosis. What is athetosis? It's slow writhing movements. A lesion of the substantia nigra pars compacta gives rise to Parkinson's. And we know what are the features of Parkinson's. There is bradykinesia, there is akinesia, short shuffling steps, there is a tremor at rest, pill rolling movement, there is a mask-like facies, etc. So this is your basal ganglia, and the answer to this is hemibalismus due to a lesion of the subthalamic nucleus of Lewis. Let's have a look at the different parts of the basal ganglia. The basal ganglia has got 5 parts. There is the caudate nucleus, putamen, globus pallidus, substantia nigra, and subthalamic nucleus. Now, caudate nucleus and putamen are together known as the striatum. 95% of the striatal neurons will secrete GABA, and 5% of the striatal neurons secrete acetylcholine and somatostatin. A lesion of the caudate nucleus, I've already told you, gives rise to what is known as chorea. C for caudate nucleus, C for chorea. Now, one word of caution here. If the question says striatum, now striatum in physiology means caudate nucleus and putamen. But if the question says corpus striatum is an anatomical term. Corpus striatum includes all 3, that is caudate nucleus, putamen, and globus pallidus, right? Putamen and globus pallidus in anatomy are known as the lenticular nucleus, right? So corpus striatum is an anatomical term, so it includes caudate nucleus, putamen, globus pallidus, but in physiology we use striatum, which is caudate nucleus and putamen, right? Globus pallidus external segment secretes GABA. Internal segment also secretes GABA, and a lesion of the globus pallidus gives rise to slow writhing movements, which are called athetosis. Substantia nigra pars compacta gives rise to secretes dopamine. Pars reticularis secretes GABA. A lesion of substantia nigra pars compacta means loss of dopaminergic neurons. This gives rise to Parkinson's. Subthalamic nucleus of Lewis secretes glutamate, which is an excitatory neurotransmitter. This now causes a lesion of the subthalamic nucleus, will cause hemibalismus. So these are the different parts of the basal ganglia, and what are the lesions, what are the neurotransmitters secreted, and what are the lesions which are produced. Right, so let's go on to our next question. Now a few topics from renal physiology. A 45-year-old man is admitted with severe dehydration due to profuse diarrhea and vomiting for 3 days. He is hypotensive, hypovolemia, hypotension, and there is going to be tachycardia. Whenever there is a hypotension, it is associated with a tachycardia. He passes a concentrated urine. We expect that. Patient has lost fluid. There is secretion of, there is a hypovolemia. It causes increased secretion of ADH. So a concentrated urine with low sodium content. Which of the following renal changes is most important in maintaining GFR in this patient? Please understand, this is an extremely important, like I said, look at the last line first. Now it says, which is the most important in maintaining GFR? There is a hypovolemia. There is less blood volume. There is less blood, less plasma flowing towards the kidneys. His GFR is reducing. Right? But what is maintaining the GFR in these kidneys is going to be what? Let's see this. So before I go on to the options, let's have a look at the basics of glomerular filtration, and then we'll come back to the question. Glomerular filtration membrane, there are 3 layers. Glomerular capillary endothelium, which is a fenestrated endothelium. There are pores which are present. Number 2 is the basement membrane, and number 3 are the podocytes. What are podocytes? The visceral layer of the Bowman's capsule is modified to form podocytes. Podocytes have these foot-like processes, and between the foot-like processes, you've got the filtration slits. So 3 layers of the glomerular filtration membrane. Remember, any neutral particle more than 8 nanometers is not filtered. A neutral particle more than 8 nanometers is not filtered in the kidneys, right? And that is why proteins are not filtered. Proteins are not present in the urine, right? So neutral particles more than 8 nanometers in diameter will not be filtered in the kidney. Fair enough? Now let us see what are the pressures which are responsible for filtration. Now this is the Bowman's capsule here. This is the afferent arteriole, glomerular capillaries, and the efferent arterioles. There are 4 important pressures here. There is a push force and there is a pull force. What is the push force? Hydrostatic pressure. So the most important pressure which is responsible for filtration is hydrostatic pressure of the glomerular capillaries. This is the most important push force. It is causing filtration, right? This is the largest force. This is the most important one, that is called the hydrostatic pressure of the glomerular capillaries. Then the glomerular capillaries have a pull force. What is the pull force? The colloid osmotic pressure. Double L in pull, double L in colloid. We've done the colloid osmotic pressure at the beginning of the session. So that is the pull force. It will pull the fluid back into the capillaries. That is called pi Gc. Pi Gc opposes filtration. What is favoring filtration? PGC, hydrostatic pressure, push force. H in push, H in hydrostatic. This is favoring filtration. What is opposing filtration is pi Gc. The two most important forces responsible here, PGC must be more than pi GC. Only then filtration will happen. Favoring filtration, PGC, opposing filtration, pi GC. Then the Bowman's capsule also has its own push force and its own pull force. The push force of the Bowman's capsule is called PBC, but look at the direction of the arrow, it is opposing filtration. And it has a pull force which is called pi BC, which is favoring filtration. It is in the same direction as PGC, so it is favoring filtration. Now, forces which are favoring filtration will be given a positive sign and opposing filtration will be given a negative sign. So what is the net filtration pressure? The net filtration pressure is PGC minus pi GC minus PBC plus pi BC. PGC is the most important force. PGC favors filtration, pi BC favors filtration, so they are both given positive signs. Pi GC and PBC oppose filtration, so they're given a negative sign. So this is your net filtration pressure, and GFR is directly proportional to the net filtration pressure. If I want to remove the proportionality sign, bring an equal to sign, I have to multiply by a constant. So GFR is equal to Kf, which is a constant, into the net filtration pressure. And what is Kf? Kf is called ultrafiltration constant. It is a product of the capillary permeability and the surface area. So these are the forces which are responsible for filtration. Which are the forces responsible for filtration? Capillary permeability, surface area, PGC, pi GC, PBC, and pi BC. Now, after we've done this basic, or we've revised the basic points of glomerular filtration, let's go back to this question. Now it says, what is maintaining the GFR in this patient? Constriction of the afferent arteriole. If the afferent arteriole constricts, there is less flow into the glomerular capillaries. Less flow into the glomerular capillaries means it is going to decrease the PGC, hydrostatic pressure in the glomerular capillaries. So that will decrease the GFR. Okay? Let's look at the next option. Constriction of the efferent arteriole. Now, if this is afferent arteriole, glomerular capillaries, this is the efferent arteriole, and here is the Bowman's capsule. So if I constrict the efferent arteriole, yes, so now there is a back pressure which will increase the hydrostatic pressure in the glomerular capillaries. And remember, this is the force which is favoring filtration. So this increases the GFR. Okay? Let's look at the third option. Increasing the glomerular capillary oncotic pressure. What was the oncotic pressure or the colloid osmotic pressure? The pull force, which was opposing the filtration. So this will decrease the GFR. Decreased glomerular capillary hydrostatic pressure, that means decreased PGC, will decrease the GFR. So what is maintaining? What is maintaining the GFR in this patient is constriction of the efferent arteriole. Efferent arteriole. This is maintaining the GFR in this patient with hypovolemia and severe dehydration. Has everybody got this question? Has everybody got this question? I'm waiting for your response, then I will move on to the next question. Has everybody got this important concept? I want you to go back with the absolute clarity of this concept, glomerular filtration. Lots of questions come from glomerular filtration. ठीक है? Is everybody okay with this? क्या हो गया? Response नहीं आ रहा. For some reason, I can't see your responses. So I am taking it for granted that you've understood this concept, and I'm going on to the next question. A 27, not year, it has to be year-old woman is evaluated for excessive thirst and passage of large volumes of extremely dilute urine, right? Excessive thirst and large volumes of dilute urine. This gives you an indication that this is a patient of diabetes insipidus. Large volumes of, that means probably ADH is either absent or ADH is not able to act. That is a question. That is a condition known as diabetes insipidus. Laboratory investigations reveal serum sodium is 150, plasma osmolality is high, urine osmolality is low. Normal urine is 300 to 1200. 300 is isotonic and 1200 is hypertonic. This is 90, so it is low urinary osmolality. A water deprivation test fails to increase urine osmolality. What is water deprivation test? You don't give water to the patient. And if you don't give water to the patient, then he should ideally produce a concentrated urine. But when I restrict water in this patient, I fail to get a concentrated urine in this patient. Yes, but after administration of desmopressin, what is desmopressin? It is ADH, antidiuretic hormone, a synthetic antidiuretic hormone. When I give him desmopressin, his urine osmolality increases to 600 milliosmoles per kg. So that means the urine becomes concentrated. That gives you an indication this is a patient who has a deficiency of antidiuretic hormone, and that is why he's producing large volumes of extremely dilute urine. Diabetes insipidus. Now the question says, in which segment of the nephron does the tubular fluid become the most dilute before the action of ADH? ADH, please remember, acts on the collecting duct, right? So the question now, I've given you 5 options here because there are so many of you who have asked me this question from different platforms. You have picked up this question and you have asked me. So I'm going to discuss, so the different questions have got different options. So I've put 5 options here so that we are absolutely clear that what happens to the tubular fluid as it passes through the nephron. For some reason, I cannot see your responses, so have no idea. I'm not sure why I'm not able to see your responses. We are stuck at Abhireddy saying hemibalismus. So I really don't know, but chalo, I'll move on. Okay. So when you look at the nephron, let us see what will happen to the osmolality of the tubular fluid as it passes through different segments of the nephron. Now, the glomerular filtrate, please remember, is isotonic with plasma. That means it has the same osmolality as the plasma. What is normal plasma osmolality? 290 milliosmoles, right? So the glomerular filtrate, which is an ultrafiltrate of plasma. What is ultrafiltrate of plasma? It is similar to plasma except it has no plasma proteins. So its osmolality is practically the same as the osmolality of the plasma. So normal plasma osmolality is 290, just for the sake 290 milliosmoles. So this is also approximately the same, except it has no plasma proteins. And proteins, as you know, their contribution to plasma osmolality is only 2 milliosmoles out of 290. So all the plasma is filtered except the proteins. So the filtrate has an osmolality practically the same as plasma osmolality, so we say it is isotonic. Now in the PCT there is a lot of solute absorption, glucose, amino acids, sodium, potassium, chloride, so many electrolytes and so many substances are absorbed in the PCT, but along with that water is going to be absorbed. So total solute and total water absorption in the PCT is to the same extent, so that the tubular fluid at the end of PCT continues to remain isotonic. A lot of reabsorption has taken place in the PCT, but total solute, total water absorption in the PCT is the same. So fluid at the end of PCT will be isotonic. In the descending thin segment, you have absorption of only water. No solutes absorbed in the descending thin segment. Only water is absorbed. So what is going to happen to the tubular fluid? It will start becoming concentrated. So at the tip of loop of Henle, it is going to be hypertonic. Very, very concentrated because only water has been absorbed. In the thick ascending limb, there is going to be absorption of sodium, potassium, and chloride. These electrolytes will be absorbed and there is no absorption of water. And please remember that the absorption of these electrolytes, sodium, potassium, and chloride, is more than the water absorption in the descending thin segment. So what is going to happen to the tubular fluid at the end of loop of Henle? It is going to become dilute, hypotonic. Okay? So isotonic at the beginning of loop of Henle, hypertonic at the tip of loop of Henle, and hypotonic at the end of loop of Henle. Why is it going to be hypotonic at the end of loop of Henle? This is because there is electrolyte absorption in the thick ascending limb, and the electrolytes, sodium, potassium, chloride, absorbed in the thick ascending limb are more than the absorption of water in the descending thin segment. Now, in the early DCT, please understand, early DCT, there is absorption of more solutes, more sodium and chloride is absorbed without absorption of water. So more dilution will take place. Keep this in mind. In the late DCT and the collecting duct, you have action of late DCT and the collecting duct. They are histologically similar. These late DCT and the collecting duct is known as the hormone regulated segment. Why is it known as the hormone regulated segment? Because hormones will act on these areas and determine the final composition of urine. Which are the hormones which will act here? ADH and aldosterone. ADH will regulate the water absorption. Aldosterone will regulate the sodium reabsorption and potassium secretion. But they will act in the late DCT and the collecting duct. Okay? So once we've revised this, now let's look at the options. In which segment of the nephron does the tubular fluid become the most dilute? So in PCT, it is isotonic. In the descending limb of loop of Henle, it is hypertonic. Ascending limb of loop of Henle, it becomes hypotonic. In the early DCT, it becomes more hypotonic, more dilute. Collecting duct, the amount of aldosterone or the ADH and aldosterone will determine the final composition of urine. Now the question here says before hormone action. That means he's trying to ask you before the fluid reaches the late DCT and collecting duct, which part of the nephron is the tubular fluid going to be most dilute? My answer here will be early DCT. If early DCT is not in the option, then my answer will be at the end of loop of Henle or the ascending limb of loop of Henle, right? So please remember, if early DCT is given in the options, then your best answer is early DCT. That is when you find that the fluid becomes even more dilute. Dilution is mainly happening in the thick ascending limb, but there is also dilution happening in the early DCT, but main dilution happens in the thick ascending limb. Okay? So this, that is why I've included all these options, so that supposing DCT is in the options, then you should go for DCT. But if it is not there in the options, then your answer should be thick ascending limb or the ascending limb of loop of Henle. Okay? I cannot see your options, pata nahi kya ho gaya hai, but your options, your chat is, I don't know why we cannot see the chat. Okay. Okay. Acha, okay, now I'm able to see. All right. Okay, maximum late DCT. Okay, all right. Okay, Avni Alankar, have you understood? Agar ye early DCT options mein hai, then that is a better answer than thick ascending limb. Agar wo nahi hai, to thick ascending limb. Is that clear? ठीक है Avni Sahil Kushwaha, ठीक है? Okay. Prem Kishore, convinced? Convinced, beta? Chal, theek hai. All right. Let's go on to the next. Now, of course, the one-liners. Let's see how are we going to respond to the one-liners. What is normal GFR? Normal GFR is 125 ml per minute or 180 liters per day. 180 liters per day. And I love telling you about this, how 1 bucket of water is 30 liters. So GFR kitna hota hai din mein? 6 buckets of water. That is the filtration which is happening in the 2 small kidneys. 180 liters per day. What is the formula for clearance? Formula for clearance is UV by P. What is U? Urinary concentration. What is V? Rate of urine flow. What is P? Plasma concentration. किसी भी substance का अगर मुझे clearance calculate करना है, then I need these 3 things: urinary concentration of that substance, rate of urine flow, and plasma concentration. I will be able to calculate clearance. What is clearance? UV by P. Maximum sodium potassium reabsorption. Maximum sodium potassium reabsorption takes place in, Maximum sodium reabsorption, sodium, potassium, calcium, chloride, bicarbonate reabsorption occurs in the PCT. Excellent. Everybody seems to have got it right. But the maximum magnesium reabsorption is going to be in the thick ascending limb. Everything else, please answer PCT. But for magnesium, it is going to be the thick ascending limb. Maximum glucose reabsorption. This occurs in the PCT. Maximum water reabsorption. 2/3 of the water reabsorption occurs in the PCT. Mechanism of sodium reabsorption in the PCT. Mechanism of sodium reabsorption in the PCT. This is a secondary active co and counter transport. Right? There is a sodium glucose co-transport, sodium amino acid co-transport, sodium inorganic phosphorus co-transport, and there is a sodium H plus counter transport. All of this occurs in the PCT. Mechanism of sodium reabsorption in the thick ascending limb. This is also secondary active co-transport, sodium potassium 2Cl- co-transport, secondary active co-transport. Mechanism of sodium reabsorption in the DCT. Sodium chloride co-transport, again secondary active co-transport. Aldosterone increases sodium reabsorption in collecting duct. Aldosterone increases sodium reabsorption and potassium secretion in the collecting duct. Absolutely right. Maximum H plus secretion. Yes, thick ascending limb, sodium potassium 2Cl- co-transport. DCT, sodium chloride co-transport. Yes, aldosterone increases sodium reabsorption in collecting duct. Vaibhav, excellent. Late DCT and collecting duct. Yes, Sheila, you're right, but it should be late DCT and collecting duct. Does not act on the early PCT. Right? Okay. Maximum H plus secretion. This occurs in the PCT, but the urine acidification occurs in the collecting duct. Absolutely right. Absolutely right. Okay. eye cells of the collecting duct are involved in secretion of H+. Which is the diuretic which acts on the thick ascending limb and inhibits the Na plus K plus 2 Cl minus co-transport? Loop diuretics, Lasix. Diuretic which acts on the DCT and inhibits Na plus Cl minus co-transport? Thiazides. Thiazides. Absolutely right. Again, all of you are getting these questions right. Yes, excellent. So happy to see your answers. Okay, great. Let's look at question number 16. Okay. Correct. Loop diuretics, thiazides. Absolutely right. A 56-year-old man presents with progressive shortness of breath, abdominal distension, bilateral leg swelling for the past 3 months. On physical, so this is obviously a patient in failure. There is pedal edema which is present. On physical examination, he has an elevated JVP with prominent V waves, right? So this is your, there is hepatomegaly with pulsations. There is a pansystolic murmur, which is best heard at the lower left sternal border that increases with inspiration. Which of the following is the most likely abnormality causing the patient's JVP findings? There is an elevated JVP with prominent V waves. So let's have a look at prominent V wave. This is a right-sided failure. Yes, this is going to be. So let's have a brief look at JVP. JVP is an extremely important topic which has been asked again and again in your exam. So JVP, we will see it on the right side. Why? Because the right internal jugular vein is in direct communication with the right atrium. So JVP will reflect all the right atrial pressure changes. Right atrial pressure changes. How do you measure the JVP? You put the patient at 45 degrees, then you use 2 scales. One scale is placed vertically on the yes, the answer is tricuspid regurgitation, but let us see. How do you measure the JVP? JVP, you take 2 scales. One scale is placed at the angle of Louis. That is placed vertically, and wherever you see the upper level of JVP, you will place a scale horizontally and measure the distance, and then you have to add 5 centimeters. The answer will be in centimeters of water, not in millimeters of mercury. It will be in centimeters of water. Right? So this is how you're going to measure the JVP. Important points about JVP, little mnemonic for this, and that is police. Palpation. Is the JVP palpable? Not palpable. O, occlusion. Is it occludable? Yes, it is readily occludable. What is the location? L, location. It is located between the 2 heads of the sternocleidomastoid. I is inspiration. What happens to the upper level of JVP with inspiration? The upper level will fall with inspiration. If it does not fall or rises, we call that Kussmaul's sign, and Kussmaul's sign is typically seen in constrictive pericarditis. C, contour. It has got multiple positive and multiple negative waves. Which are the positive waves? A, C, V, and negative waves are X descent and Y descent. Okay. Erect position. What will happen when the patient is in the erect position? The upper level falls. Yes? Okay. So everybody is putting in your putting in comments about the JVP, pansystolic murmur, yes, the Carvalho sign, and you've got, yes, bilkul sahi. Better seen than felt is JVP. Better felt than seen is carotid pulse. Now, when I look at the JVP with the cardiac cycle, I'm just going to revise this with you. You know that there is a ventricular systole, ventricular diastole. So the first thing is, let's see the heart sounds with the cardiac cycle. At the onset of ventricular systole, you have the first heart sound, which is due to the closure of the atrioventricular valves, mitral valve and tricuspid valves. Then at the end of ventricular systole, you have the second heart sound, which is due to closure of the semilunar valves, aortic and pulmonary. S3 is heard in the first rapid filling phase. This is because of rapid flow of blood, sudden inrushing of blood from the atrium to into the ventricles. And S4 is normally not heard, but it is heard in patients with decreased ventricular compliance. S4 will be heard in the second rapid filling phase. Second rapid filling phase, please remember, is due to atrial systole. So this is your cardiac cycle. Remember, ventricular systole is divided into, this is ventricular systole, which is divided into isovolumetric contraction, rapid and slow ejection phase. Then you have a ventricular diastole, which is isovolumetric relaxation, rapid filling, first rapid filling phase, diastasis, second rapid filling phase, which is due to atrial systole. So between S1 and S2 is ventricular systole, right? Isovolumetric contraction and ejection phase. Between S2 and the next S1 is ventricular diastole. So S3 is heard in diastole. S2 means onset of ventricular diastole. S3 is heard in the first rapid filling phase. S4 is not heard all the time. It is heard only in patients who have a decreased right ventricular compliance. S4 coincides with atrial contraction. Okay? Now let's see the JVP. 3 positive waves. Which are the 3 positive waves? Positive waves means outwardly directed. You've got ACV and 2 negative waves, which are inwardly directed, X descent and Y descent. So A wave is due to atrial contraction. So this is your A wave here. A wave, atrial contraction, is responsible for the second rapid filling phase of the ventricles, right? Atrial contraction. This produces atrial contraction increases the pressure within the right atrium, which causes a positive wave on the JVP. So A wave will be seen here, atrial contraction. C wave is seen in isovolumetric contraction phase. What is C wave due to? It is due to bulging of the closed tricuspid valve into the right atrium during isovolumetric contraction. Then you have the X descent, the first negative wave. What is X descent due to? This is due to a downward pull of the closed tricuspid valve during the phase of ejection, and this is also due to atrial relaxation. 2 things, which causes a decrease in the right atrial pressure and a negative wave on the JVP. What are the 2 things? Number 1, a downward pull of the closed tricuspid valve, and number 2, atrial relaxation, which occurs in this phase. This is responsible for the C wave of the JVP. X descent of the JVP. A wave, atrial contraction. C wave, bulging of the closed tricuspid valve into the right atrium during isovolumetric contraction. X descent due to a downward pull of the closed tricuspid valve during the ejection phase, plus atrial relaxation during this phase. Then you have the V wave. V wave is due to venous filling of the right atrium just before opening of the tricuspid valve. You know, how does the right atrium get filled up? It gets filled up by the blood coming from the superior and the inferior vena cava, right, into the right atrium. This is the right atrium here and the right ventricle. Okay? Then you have Y descent. Y descent is in the first rapid filling phase. Why is there a negative wave in the first rapid filling phase? Because blood is rushing into the right ventricle during the first rapid filling phase. Absolutely right. Okay. Great. So these are the waves with the cardiac cycle. Now the question here says there's a prominent V wave. Normally, what is the V wave due to? It is due to venous filling of the right atrium just before opening of the tricuspid valve. But if the tricuspid valve does not close properly, right? If the tricuspid valve does not close properly, then blood will also regurgitate from the right ventricle into the right atrium, causing a very large V wave. A large V wave will be seen typically in tricuspid regurgitation. Tricuspid regurgitation, right? So this question here, which I've asked you, prominent V waves, and there are signs of right ventricular failure here. So this is going to be a tricuspid regurgitation. Tricuspid regurgitation. Please remember, mitral stenosis will not affect the JVP. JVP will be seen when there are problems in the right side of the heart. Right? Now let's see cardiac tamponade and constrictive pericarditis. So the next thing which I'm going to do with you is the abnormal JVP. So when do you get a prominent A wave? Remember, A, C, X descent, V wave, and the Y descent. So when is there going to be a prominent A wave? A wave is due to atrial contraction. That means prominent A wave means stronger atrial contractions. Stronger atrial contractions will be seen in tricuspid stenosis, or a decreased right ventricular compliance, any condition which reduces the right ventricular compliance. Right? So tricuspid stenosis and a decreased right ventricular compliance. Cannon A wave. Cannon A wave means very large A waves. So normally when the right atrium contracts, the tricuspid valve is open and blood goes from the atrium into the ventricle. But it can happen in a condition which is known as atrioventricular dissociation. What is atrioventricular dissociation? That means when the right atrium contracts, the tricuspid valve, instead of being open, is closed. So the entire force of the right atrium is reflected in the JVP and you get a cannon A wave. Yes, this is seen in complete heart block. Absolutely right. This is seen in what is called atrioventricular dissociation, which is seen in complete heart block, also known as junctional rhythm. Absent A wave. So absolutely right, all of you. Absent A wave will be seen in atrial fibrillation. Large V wave, we've just discussed, tricuspid regurgitation. Sharp X descent plus absent Y plus a pulsus paradoxus. This is seen in cardiac tamponade. A prominent X plus prominent Y. This is seen in constrictive plus cosmols. Is seen in constrictive pericarditis. Yes, Juberali. Yes, I agree. I'm just giving you only the most important, as far as there are many other conditions where you're going to see this, but yes, Epstein anomaly, absolutely right. But I'm just giving you the common conditions, right? So prominent X plus a prominent Y, which is also called the W sign or the M sign, that is going to be seen in constrictive pericarditis. In cardiac tamponade, sharp X plus blunted Y plus pulsus paradoxus. X here, X here. So this is your cardiac tamponade. Absolutely right. So this is an extremely, extremely important table. And as I can see, this is also been done by the medicine faculty. So you should not have any problem in answering questions on the JVP. Okay, let's have a look at the next question. It says that a 60-year-old man with long-standing hypertension and atherosclerosis is found to have a 50% narrowing. That means the radius has become half. 50% narrowing of the lumen of his left of his left renal artery on Doppler ultrasound. Renal blood flow through this artery is assessed under steady laminar flow conditions. According to the Hagen-Poiseuille's law, if all other factors remain constant, the blood flow through this artery will be reduced to approximately what fraction of the normal? So Hagen-Poiseuille's law states that flow is equal to yes, it is going to be 1 by 16 because flow is inverse to the fourth. Flow is directly proportional to the fourth power of radius. If radius has become half, the flow will also become 1 upon 16. Resistance is inverse to the fourth power of radius, but flow is directly proportional to the fourth power of radius. Right? Flow is equal to pi by 8 into delta P r to the power 4 divided by neta L. What is delta P? Pressure gradient at the two ends of the tube. R is the radius. Neta is viscosity. L is length. Right? So if the radius has become halved, then 1 upon 2 raised to the power of 4 will become 1 upon 16. So flow is directly proportional to the fourth power of radius. Please remember that. Resistance is inverse to the fourth power of radius. So if the question says what happens to resistance, then we will say 16 times increase in resistance. Right? But remember, flow is directly proportional to the fourth power of radius. So less the radius, less the flow. Radius has reduced by half, flow has reduced by 1 upon 16. Okay? Or flow has become 1 upon 16. Okay. Okay, has everybody got this question? Okay. Sorry. Let's go on to our next question. One-liners. Blood vessels which contribute the maximum to systemic vascular resistance. Systemic vascular resistance. So that means when we talk of which blood vessels, which category of blood vessels, is it going to be aorta, arteries, arterioles, capillaries, venules, veins, vena cava, which are contributing maximum to resistance? Oh, Jugular says, please again. Okay, the previous question I'm yes, all right. So these are actually 2-3 important points here. Let me just discuss it with you. Okay. So the first is that the flow is equal to delta P by R. This is one formula. That is, flow through any tube will be equal to the pressure difference at the two ends of the tube, will be directly proportional to the pressure difference at the two ends of the tube, and inverse to the resistance to flow. So this is first formula. Then resistance is equal to 8 neta L over pi R4. What is neta? Neta is viscosity, L is length, R is radius. Resistance is inverse to the fourth power of radius. But if I substitute this second formula in the first one, then what do I get? Flow is equal to delta P into pi R4 over 8 neta L. I will take pi by 8 outside into delta P R to the power 4 divided by neta L. So in other words, flow is directly proportional to delta P. Flow is directly proportional to fourth power of radius. Flow is inverse to viscosity. Neta is viscosity and L is length. Have you understood? So the question says, now, the question has asked you about flow. Right? Has asked you about flow. Flow is directly proportional to fourth power of radius. If radius has become half, flow will become 1 upon 2 raised to the power 4 or 1 upon 16. Jugular? Have you got this? Take it? Okay. So let's look at the one-liners. Yes, a lot of you have answered this question. Blood vessels which contribute maximum resistance is going to be arterioles, not arteries. Small vessels. ये किसने बोला? साहिल खुशबा? ये तो बड़ा smart answer है. Small vessels mean arterioles. Arterioles are the site of peripheral resistance. ठीक है? Not venules, प्रेम किशोर, बिल्कुल भी नहीं. Right? Arterioles. Arterioles are thick-walled with lot of smooth muscle. Thick-walled with lot of smooth muscle. So arterioles are the site of peripheral resistance. Right? Okay. All right. Phase of the cardiac cycle which follows the first heart sound. Between the first and the second heart sound is isovolumetric. क्या हुआ बेटा? Sorry. Volume. Okay. The mic fell down. Sorry. Okay. Should be okay now. Acha, ab aa rahi आवाज यासिर खान? Okay. Voice is okay now? Sorry, the mic fell. All right. Ab theek hai? Okay. So phase of the cardiac cycle which follows the first heart sound will be isovolumetric contraction phase. है ना? Between the first and the second heart sound is ventricular systole, and the first phase of ventricular systole is isovolumetric contraction phase. After that is the ejection phase. Heart sound associated with first rapid ventricular filling phase is going to be the third heart sound. And third heart sound coincides with Y descent. Right? Wave of ECG which depicts ventricular depolarization. Answer this please. Which wave of ECG depicts the ventricular depolarization? A wave is atrial depolarization. Sorry, P wave is atrial depolarization. QRS complex is ventricular depolarization. And T wave is ventricular repolarization. So this is going to be QRS. Okay? Okay. What is the absolutely right? Everybody's got it correct. Yes, QRS, absolutely right. Normal resting cardiac output. This is 5 liters per minute. During exercise, this resting cardiac output can increase to 20 to 22 liters per minute. Okay? All right. What is TVR? T wave is ventricular repolarization. All right. Baroreceptors are located in carotid sinus and aortic arch. Baroreceptors. What are baroreceptors? These are involved in minute-to-minute regulation of blood pressure. So this is going to be carotid sinus and the aortic arch. If the baroreceptors are stimulated, there will be a decrease in the sympathetic outflow and increase in parasympathetic outflow to the heart and the blood vessels. That means there will be a decrease in blood pressure and a decrease in heart rate. Whenever the baroreceptors are excited, what is going to happen? Senses BP, absolutely right. Carotid sinus, aortic arch, not carotid body and aortic body. No. Carotid body and aortic body are chemoreceptors. They are involved in regulation of respiration. Baroreceptors are involved in regulation of blood pressure. Please understand that. Nerva pressure, it is not carotid body and aortic body. It is carotid sinus and aortic arch. Whenever the baroreceptors are stimulated, there will be a decreased sympathetic. That means decrease in blood pressure and decrease in heart rate. Absolutely right. Yes. Basal-gyrus reflex causes what? Absolutely right, Prem Kishore. There is going to be a hypotension. There is a bradycardia. Bilkul sahi. Plus, it can also affect respiration. Apnea followed by rapid shallow ventilation. Apnea followed by rapid shallow ventilation. Hypotension bhi hoga, bradycardia bhi hoga, and apnea, that means respiration stops, followed by rapid shallow ventilation. Okay? Okay. Yes. So remember, it can affect respiration as well. Okay? All right. Basal-gyrus reflex mein vagal C fibers are affected. They are stimulated. So it can cause bradycardia, hypotension, bradycardia, and vagal C fibers are stimulated. So hypotension, bradycardia, and apnea followed by rapid shallow ventilation. Okay? Okay. All right. So coming almost towards the end of, no, we still have about 5 or 6 questions left. Yes, where are we? I think question number 20. Future you is watching. You is you watching. What is this? What does this line, one line mean? Future you is watching. That means what you're doing today will affect your future, isn't it? So the point I'm trying to make over here is that the future you should have no regrets. So put in your maximum at this point. These few days before the exams, you have to put in all your effort. Forget about everything else. This time will never come back. So want you to put in all your efforts towards this exam. We have to clear this exam so that our life can move forward. So future you is watching. That means do not have any regrets. You will not have any regrets if you've put in your best now. Put in your best now, no regrets later. This is, yes, absolutely right. This is something which I want you to carry with you and make sure that there is no, even all your efforts, whatever you can put in those efforts now so that no regrets later. Absolutely right. Time to show your efforts. Bilkul sahi. Let's go on to the next question. A 60-year-old patient complains of breathlessness on climbing the stairs. On auscultation, heart sounds are normal. Normal breath sounds are heard in bilateral lung fields. Flow volume loop is shown, or the one which is marked in blue. Flow volume loop is comment on the diagnosis. Is this obstructive or is this a restrictive lung disease? So let's have a look at these flow volume curves, flow volume loops. Let me try and do as rapid revision as possible. Now, when I look at a flow volume curve, expiration is above the horizontal and inspiration is below the horizontal line. This is a normal expiratory flow volume loop, and this curve, and this is the inspiratory curve. This is expiratory curve, this is inspiratory curve. You start this with total lung capacity, and this is residual volume here. Yes? Okay, let me make this a little better. This is what is called a flow volume loop. Now, what happens in obstructive lung disease, bronchial asthma, COPD? Let's try and see if this is a normal flow volume loop. In the case of bronchial asthma or any obstructive lung disease, this is what it looks like. If you look at the expiratory curve, the shape is abnormal. It is called a scooped curve. It is called a coved curve. Coved curve. Right? So this is your obstructive lung disease, scooped curve. This is seen in all obstructive lung diseases, emphysema, asthma, COPD. Ananya, your words also mean a lot to me. Thank you very much. All right, so this is obstructive lung disease. Let's see what happens in restrictive lung disease. Here is a normal flow volume curve, flow volume loop. In restrictive lung disease, the loop is shifted to the right. Absolutely right. Restrictive lung disease, it is tall and narrow, right? It is tall and narrow and shifted to the right. This is restrictive lung disease. And this is what is seen in the question which I've given you. This is a restrictive lung disease. This is parenchymal restrictive lung disease like pneumoconiosis, asbestosis, interstitial lung disease. So this is restrictive lung disease. What happens in large airway obstruction? Large airway obstruction. Let's see this. This is my normal flow volume loop. What is large airway obstruction? Large airway obstruction is seen in foreign bodies, tumors, etc. In large airway obstruction, it is a box type of a loop. This is seen in a large airway obstruction, right? Foreign body, tumors, etc. It's called a box loop, box type of a loop. Absolutely right. Yes, pulmonary fibrosis, an excellent example of parenchymal restrictive lung disease. TK, right? So this is as far as your flow volume loops are concerned. Once again, if it's a scooped out loop, that means it is obstructive lung disease. A tall and a narrow loop shifted to the right, this is your restrictive lung disease due to parenchymal causes, and a box loop is typically seen in large airway obstruction. Okay? So this is as far as your parenchymal restrictive disease. This is seen in, like I said, in a typical example of parenchymal restrictive pulmonary fibrosis, pneumoconiosis, asbestosis, etc. Clear? Chaliye. Let's go on to our next question. Which of the following describes a phenomena in RBCs where bicarbonate ions are exchanged for chloride ions to maintain electrical neutrality? This is what is known as the Hamburger effect, or also known as the chloride shift. Right? Hamburger effect or the chloride shift. So let me discuss this Hamburger effect with you. Now, Hamburger effect is seen in the venous RBC. Right? Venous RBC. Now, CO2 plus water in the presence of carbonic anhydrase. RBCs are very rich in carbonic anhydrase. Thank you for the burger, Sahil Kushwaha. I think we all need that now. Yes. So carbon dioxide plus water in the presence of carbonic anhydrase forms H2CO3. Remember, RBCs are very rich in carbonic anhydrase. Now, this H2CO3 will split into H plus and HCO3 minus. The H plus will be buffered by the hemoglobin in the RBCs. But what happens to bicarbonate? This is exchange. It moves out of the venous RBC. It is exchanged for chloride. And this exchange of bicarbonate and chloride is done by a protein which is called anion exchanger 1. What is anion exchange? It is a mutual exchange of anions based on their concentration gradients. So chloride moves out of the cell and bicarbonate moves out of the cell and its place is taken by chloride. And what follows the movement of chloride is also water. So RBC, the venous RBC becomes plumper. It becomes like the burger patty. That is why it's called Hamburger effect. This anion exchanger 1 was earlier known as a band 3 protein, but today we call it anion exchanger 1. Right? So this is what is known as chloride shift. And because of this chloride shift or the burger effect, the venous hematocrit is 1 to 2% or 2 to 3% more than the arterial hematocrit. Venous hematocrit is slightly more than the arterial hematocrit. This is because the venous RBC has become more larger in size. It has acquired water, right? So it has become larger in size. Therefore, the venous hematocrit is more than the arterial hematocrit. This is known as the chloride shift or the hamburger effect. Let's look at the next question. A 55-year-old man presents with recurrent epigastric pain. There is chronic diarrhea. There is significant weight loss. He has multiple peptic ulcers. Yes, so that means there is definitely increased secretion of acid. The treatment, the patient, whenever there is hyper secretion of acid, we generally give proton pump inhibitors, isn't it? Now, this patient is refractory to proton pump inhibitors, omeprazole, pantoprazole. Refractory, does not respond to proton pump inhibitors. Upper GI endoscopy reveals multiple ulcers in the duodenum and the jejunum. Fasting gastrin level is markedly elevated. Which of the following hormones is responsible for this patient's condition? Has to be gastrin. Though, of course, the hint is given in the question itself. This is a gastrinoma, Zollinger-Ellison syndrome. Yes, so this is great. What is the role of CCK? So gastrin will increase the HCl secretion. What is the role of CCK, cholecystokinin? It increases the gallbladder contraction. It also increases the pancreatic enzyme secretion. What is the role of secretin? Secretin will increase the bicarbonate content in bile and pancreatic secretions. What is the role of somatostatin? Somatostatin will decrease the gastric secretion and motility, and it will also decrease the intestinal secretion and motility. Somatostatin will decrease the secretion and decrease the motility. Gastrin increases HCl secretion. CCK will increase gallbladder contraction as well as increase the pancreatic enzyme secretion. Secretin will increase the bicarbonate content in bile and pancreatic juice, making them more alkaline, right? And somatostatin, like I said, will decrease motility, secretion, both in the stomach as well as in the intestine. Okay. A 6-month-old infant is brought to the pediatric clinic with chronic watery diarrhea, abdominal distension, poor weight gain since the introduction of formula feeds. The mother notes that the stools are acidic and frothy. Symptoms improve when milk products are avoided. So this is giving you a hint that this child has developed lactose intolerance. Which of the following is the most likely defect responsible for the child's condition? Now, lactose is digested in the small intestine. Disaccharides, sucrose, lactose, maltose, they are digested in the small intestine by disaccharadases. Which are the disaccharadases? Lactase, sucrase, maltase, isn't it? So, what is going to cause a lactose intolerance is absence of the brush border lactase enzyme. What happens if there is deficiency of lipase? In lipase, that causes a steatorrhea. Deficiency of pancreatic lipase means there is going to be a steatorrhea. Here, the stools in this patient will be bulky, greasy, right? That is steatorrhea. If there is decreased secretion of intrinsic factor, there will be a vitamin B12 deficiency, right? But won't affect the stools, right? So again, a decreased bile salt secretion, steatorrhea. All right. Okay, let's look at question number 22. A 68-year-old man with long-standing diabetes presents with early satiety, nausea, bloating, and postprandial vomiting. His symptoms are worst after large meals. Upper GI endoscopy shows no mechanical obstruction. Gastric emptying scintigraphy demonstrates delayed gastric emptying. That means there is something which is obstructing the movement of food from the stomach into the small intestine. Delayed gastric emptying. That is why he has early satiety, nausea, bloating, postprandial vomiting also. Yes? Which of the following gastrointestinal movements is impaired in this patient? Primary peristalsis of esophagus. Primary peristalsis of esophagus is going to push the food from the stomach into, from the esophagus into the stomach. Yes, if peristalsis of the esophagus is affected, then he will have regurgitation, right? Migrating motor complex of small intestine occurs in the fasting state. It is not related to meals. So this is also not the answer. Antral peristaltic contractions. The peristaltic contractions in the antrum of the stomach will push the food from the stomach into the small intestine. So these are affected. Yes? So answer will be C, not B. Please remember, migrating motor complexes of the small intestine occur in the fasting state. Yes, this is typically, Sheila Sahani has typically said, this is a typical patient of gastroparesis. Yes? Gastroparesis. Receptive relaxation of the stomach occurs during swallowing. During swallowing, the stomach will relax to accommodate that food. Yes, again, if the receptive relaxation does not happen, there will be regurgitation. But this clinical scenario is a typical case of gastroparesis. So answer will be C. Excellent. Everybody seems to have got it right. Okay. This is not GERD. This is not GERD, gastroesophageal reflux. This is typically a case of delayed gastric emptying. Take it? Okay. A patient with known brain tumor learns that his pituitary stalk has been affected. Yes? Secretion of which of the following hormones would be likely to be increased after sectioning of the pituitary stalk? Now, what happens? Hypothalamus. Between the hypothalamus and the pituitary, you have the hypothalamo-hypophyseal portal system. So hypothalamus sends a number of releasing and 2 inhibiting hormones towards the anterior pituitary, and these releasing and inhibiting hormones will affect the secretion of the anterior pituitary hormones. Yes? Now, which are these? Let's have a look. From the paraventricular nucleus of hypothalamus, corticotropin releasing hormone will act on the anterior pituitary and increase the secretion of adrenocorticotrophic hormone. TRH, thyrotropin releasing hormone, will act on the anterior pituitary and increase the secretion of TSH. From the arcuate nucleus of the hypothalamus, GnRH, gonadotropin releasing hormone, will increase the secretion of FSH and LH. Growth hormone releasing hormone will increase the secretion of growth hormone. Somatostatin will decrease the secretion of growth hormone. Another inhibiting hormone is prolactin inhibiting factor, which is also called dopamine. This will reduce prolactin secretion. So 2 inhibiting hormones. So if the pituitary stalk is affected, then these hypothalamic hormones cannot reach the anterior pituitary. So all the hormones, ACTH, TSH, FSH, LH, even growth hormone will be reduced. Why growth hormone will be reduced? Because the major hypothalamic hormone affecting growth hormone secretion is GHRH, not somatostatin. Somatostatin has a minor role. But which hormone will show an increase? That is going to be prolactin. Prolactin. This is also known as the stalk effect. So prolactin is the answer here. Prolactin hormone is the one which will increase. Absolutely right. Let's go on to the next question. Now this says that a 42-year-old woman presents with progressive fatigue, weight gain, cold intolerance, constipation. For the past 6 months, she also reports menorrhagia, difficulty in concentration. So weight gain, cold intolerance, bradycardia, dry, coarse skin, periorbital puffiness. This is hypothyroidism. TSH is elevated, free T4 is low, anti-thyroid peroxidase antibodies. This is typically seen in Hashimoto's thyroiditis. Hashimoto's thyroiditis. Yes. Graves' disease is hyperthyroidism. In subacute thyroiditis, this is generally post-viral infection, and plus, very importantly, the thyroid gland is tender in subacute thyroiditis. Yes. So Hashimoto's thyroiditis. Absolutely right. This is identify the hormones A and B responsible for negative feedback on the hypothalamus pituitary axis. This is a question from your exam. What is A and what is B? A is secreted by the Sertoli cells. A is secreted by the Sertoli cells, and it causes a negative feedback effect on the secretion of FSH. So this is inhibin. B is secreted by the Leydig cells. It has a negative feedback effect on the secretion of LH, and that is testosterone. So answer will be inhibin and testosterone. Inhibin and testosterone. Excellent. Sorry. Sorry, I need to. Okay, all right. One-liners. Let's have a look at the last bit of one-liners from endocrinology. Hormones with nuclear receptors. Extremely important hormones with nuclear receptors will be thyroid and estrogen. A question which has been asked again and again, thyroid and estrogens. Hormones which do not require second messengers. This is insulin and insulin IGF. Why not insulin and IGF-1? Because the receptor itself has tyrosine kinase activity. Receptor itself has tyrosine kinase activity. Growth hormone, prolactin, leptin, erythropoietin, they act via the JAK-STAT pathway. So they do not need second messengers. Right? Next important one-liner, which is the hormone which uses cyclic GMP as a second messenger. Answer is atrial natriuretic peptide. Zona glomerulosa secretes aldosterone. Zona fasciculata, mainly glucocorticoids. Zona reticularis, mainly androgens. Hormone responsible for lactopoiesis and lactokinesis. Two extremely important points. Lactopoiesis means increase in the milk production and therefore increase in the milk secretion. That is prolactin. Prolactin will increase the milk proteins, therefore increase the milk secretion. And the hormone responsible for lactokinesis, or the movement of milk, that is milk letdown, that is oxytocin. So lactopoiesis and lactokinesis, right? So this is as far as your one-liners from endocrinology is concerned. And we have come to the end of our session, right? Oh, I have one more slide. one more slide, which is your one-liners of endocrinology, but the answers are already given over here. We can quickly go over these. Beta cells of pancreas will secrete insulin plus amylin. But please remember, the major secretion is obviously insulin. Insulin is secreted 100 times more than amylin. Amylin is not C-peptide. Please remember, amylin is not C-peptide. What is the action of amylin? It causes satiety. It will decrease the glucagon secretion, and it decreases the gastric emptying. Decreases the gastric emptying. Right? Target organs for insulin: adipocytes, muscle cells, liver. Target organs: alpha cells of the pancreas secrete glucagon. Target organ for glucagon is the liver. Parathormone receptors on osteoblasts. Calcitonin receptors, osteoclasts. C in osteoclast, C for calcitonin. Action of parathormone on PCT: decreases phosphate reabsorption, which is called a phosphaturic action. Action of parathormone on DCT: increases calcium reabsorption. Action of vitamin D: increases calcium and phosphate absorption in the intestine as well as in the kidneys. Okay. All right. Now, yes, cyclic GMP is ANP and BNP. Absolutely right. Himanshu says, in the GFR question, as the efferent arteriole would constrict, it will initially decrease the GFR, but eventually increase the GFR. So you must understand, if you look at that question, yes, what you're saying, Himanshu, is right. Severe efferent arteriolar constriction will result in a decrease in GFR, but mild to moderate will increase the GFR. So question says, what is maintaining the GFR in a patient where there is hypotension and hypovolemia? In that case, my answer will be efferent arteriolar constriction. And I gave you the other options cannot be the answer. Have you understood? All right. Yes, World Gaming, I tried my best to cover majority of your physiology, major part of your physiology. Okay, Yasir Khan and Himanshu, are you convinced? Okay, PDF I will give you. Thank you for this session. Thank you. I'll be ready for all your interaction and all your answers. Extremely thankful to all of you. Last parting shot from me: show up, revise, repeat. What does that mean? What is show up? Every day you have to motivate yourself that I will use this day to the maximum possible. I will do the maximum possible revision that is possible. I will put in my maximum effort. This is what you're going to do every day, not a day to be wasted. You have to show up every day. Right? So use this time to the maximum possible advantage. This time will not come back. And what did I tell you? The future you is watching you. So thank you very much and all the best, and my best wishes and blessings to each one of you. Thank you very much.